بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we are going to discuss a new subject in the musculoskeletal imaging, which will be about the diagnosis of musculoskeletal infections. And this will involve the infection of the bone, infection of the joints, as well as infection of the muscles and the related subcutaneous and subcutaneous tissues and the facial planes. And here are the topics that we would like to cover in this topic, and we'll start by the inflammation of the skin, and this is known as cellulitis, which is an acute infection of the dermis and the subcutaneous tissues, and this is not an infectious disease that can be transmitted from one to another. It is related to the presence of some infective organisms in the subcutaneous tissues, especially known in patients with diabetes, because they have the peripheral vascular disease, and the nourishment of the skin and the subcutaneous tissues is relatively poor, and this will lead to the susceptibility of inflammatory changes. Actually, the diagnosis of cellulitis is easy from the clinical point of view, but sometimes you may need to look for the possible complications. One of the best imaging modalities here is ultrasound. It is, of course, rapid, and at the same time, it is a dynamic examination. And whenever you have the ultrasound and you got some echogenicity of the skin and the haziness of the subcutaneous tissues with edema in the subcutaneous tissues, which will give the copelestone appearance, and also you may see hypoechoic or anechoic bands of fluid in the subcutaneous tissues, as you can see here. The complications of cellulitis include deep extension of the infection, the formation of soft tissue abscesses, extension of the infection to the underlying muscles. If the infection is aggressive, it may lead to necrotizing fasciitis. Also, if it reaches the bone, it may lead to osteomyelitis, and whenever infection is near to vessels, it may lead to thrombophlebitis. Then we came to this very important issue, which is the osteomyelitis, which means that there is infection of the bone as well as of the medullary cavity, and this is typically occurred by bacteria. It can affect any age, and the most common age group to be affected are between 2 and 12 years of age, and there is some male predilection. In most of the cases, the bacteria or the organism reaches the bone by hematogenous spread through the bloodstream. But sometimes this may occur by direct extension secondary to trauma, or even previous surgery, or the presence of skin ulcers that may transmit the infection to the underlying bone. Staphylococcal aureus is the most common pathogen, which can be isolated in about 90% of the cases. However, in up to 50% of the cases, no organisms can be recovered. And the location of the osteomyelitis has some age distribution, and in the neonates, it affects the metaphyses and or the epiphyses, while in the children, it predominantly affects the metaphyses. In adults, there is epiphyseal affection and the subchondral extension. Then that's what happens if the organism reaches the bone, and the nutrient arteries are considered as end arteries. Whenever the bacteria came through the nutrient artery, they will initiate an acute inflammatory response that will result in tissue necrosis and breakdown, leading to obstruction of the vessel and consequently a vascular necrosis of the affected bone, leading to dead bone, which is known as the sequestrum, and this will end by the stage of chronic osteomyelitis. Before the formation of necrotic tissue, sequestra, and this is known the acute stage, and after the necrosis, sequestration, and new bone formation, which is known as involucrum, and this is the chronic stage, as I will discuss. Then the earliest sign of acute osteomyelitis is the changes in the soft tissues adjacent to the affected bone, which may become swollen, and sometimes you may notice that there is blurring of the fat planes around the bone or near the joint to be affected. And sometimes, because most of the inflammatory changes are near to the joint in the epiphysis or in the metaphysis, then you may have a joint effusion of the nearby joint. And in order for the lesion to appear in the plain X-ray, about 40% of the bone mineral density has to be lost. And this may take some time, which is considered as a latent period between the time that the organism has reached the bone and the initial appearance of the bony changes in the X-ray. This latent period is about 7 days in children and about 2 weeks in adults. The changes that are suspected to appear in the plain X-ray include regional osteoporosis or osteopenia, then periosteal reaction, and osteolytic lesion of the affected bone, usually in the cortex, and there may be some endosteal scalloping. Then the normal bony trabeculae are lost in the affected area, and after some time there may be new bone apposition and the peripheral sclerosis, and in the chronic untreated cases you may get sequestrum, involucrum, and cloaca, as I will show to you. Then this is the bacteria seeding into the bone, resulting in focal area of bone marrow cellulitis. Then inflammation will compromise the blood flow, causing necrosis. And infection is forced through the vascular channel into the cortex. This is the site of the entrance of the nutrient artery, where the infection will retrograde, pass through the same route into the subperiosteal area, leading to periosteal elevation and subperiosteal new bone formation. The central part of the bone will become necrotic and dead, and this is known as sequestrum. The periosteum will deposit new bone along the area where it is elevated, and this is known as involucrum. And this is an example of acute osteomyelitis of the distal phalanx of the big toe. And you can see this erosive changes, which are relatively ill-defined with soft tissue swelling, and you may be able to see some air loculi within the infected area. And this is another example of hematogenous osteomyelitis of the distal part of the radius. And within 2 weeks of presentation, you got some erosive changes in the distal part of the radius. Then within 3 weeks, you may got some new bone formation. And in the course of about 8 weeks, you got considerable healing at the site of the infection. Then CT is considered somewhat insensitive. It will show most of the changes that appeared in the plain X-ray. But actually, there are some changes that will not be seen in the plain X-ray nor in the CT, particularly in the very early stage of bone marrow edema, where only MRI is able to see these changes within the bone. Then the CT may have low sensitivity and specificity even in chronic cases, and the limitations of CT are mainly due to its inability to detect bone marrow edema, and sometimes you may got artifacts from metallic implants or some foreign bodies. Then bone marrow edema, which is the earliest sign of acute osteomyelitis, is seen only by MRI, and this can be detected as early as 1 to 2 days after the onset of infection. You do not need to wait for 7 or 14 days. The bone marrow edema, as you all know, is of low signal in the T1 and high signal in the T2, and if you inject contrast, the bone marrow edema will enhance. And you remember my words that I always repeat: bone marrow edema of whatever etiology, either traumatic, inflammatory, degenerative, neoplastic, if you give contrast material, bone marrow edema will enhance of whatever etiology. And here you see a case of osteomyelitis of the proximal tibia, where the plain X-ray looks absolutely normal. An MRI, you can see bone marrow edema in the tibia. You see some breaching of the physial plate into the epiphysis. The bone marrow edema in the T2 weighted image is of bright signal. And this is an extensive case of acute osteomyelitis of the hind foot, affecting mainly the calcaneus and some of the tarsal bones. And you see the erosive changes of the calcaneus, but on MRI you can see how severe is the disease. And there is extensive destructive changes in the calcaneus and inflammatory granulation tissue in the surrounding fat planes, and also you see the lesions that are appear of bright signal in the T2 weighted image. And also in the axial image, you can see the soft tissue inflammation. All what appears bright in this stir image represents fluids in the soft tissues indicative of inflammation. Then in this case, you may see that this shoulder appears showing no abnormality actually, but this patient had an osteomyelitis, and the ultrasound showed the presence of supraosteal fluid collection near the humeral metaphysis, which cannot be elicited in the plain X-ray. As I have mentioned before, that ultrasound is one of the good imaging modalities, and it has a major role in the musculoskeletal imaging. Of course, bone scan and the indium labeled white BC scintigraphy, gallium citrate, and PET-CT may help in localization of the site of infection, but as you all know that the findings are non-specific, because they may be secondary to trauma. This uptake in regional uptake in the area, in the inflamed area, may be also the sequelae of other underlying pathologies. Then in cases of chronic osteomyelitis, and you got this appearance, you see some holes in the bones, or let's say cavities, and these cavities may contain sclerotic bone fragments, which represent the dead bone or the sequestra, and these cavities may be communicating to the outside through openings, and these openings are known as cloaca. And sometimes these openings are persistently discharging inflammatory fluid or even pus, and you may need to perform this technique, which is known as sinography, in order to delineate the track where it is connected to inside the bone in the medullary bone, where an abscess cavity is opacified. Another example of chronic osteomyelitis, in where you got this dense bone representing sequestra, the opening where the dense bone is extruded through the medullary cavity is known as cloaca, and the new bone formation along the shaft of the bone is known as the umbiliculum. And this is a case of the fracture of the femur, and there is also manifestations of chronic osteomyelitis in most of the distal part of the femur, where you got the cavities within the bone, and you got dead bone representing sequestra, and also you can see the dense bone along the shaft representing the supraosteal new bone formation or the umbiliculum. Then these are the complications of osteomyelitis. Osteomyelitis may result in sinus tract formation, discharging pus, may sometimes superimposed by the development of squamous cell carcinoma, which is known as Marjolin ulcer, and osteomyelitis. The bone affected by osteomyelitis may be subjected to the possibility of developing an osteosarcoma, which is a rare possibility. There may be pathological fractures or secondary amyloidosis. The differential diagnosis of osteomyelitis, especially in the chronic phase, may include the Charcot joint, we'll describe in detail, then bone metastasis, Ewing sarcoma, osteosarcoma, bone lymphoma, maybe multiple myeloma, and histiocytosis. And this is an example by MRI of an osteomyelitis in the distal part of the femur, where you got bone marrow edema in the T1, bright in the T2. And if you look carefully, you can see a cavity within the bone marrow edema representing an abscess, and this abscess contains the proteinaceous fluid or pus, which is somewhat bright in the T1 and also bright in the T2, indicating the presence of proteinaceous fluid. Then you know that fungal osteomyelitis is also one of the bone infections, but is seen in usually the immune compromised patients, and the most commonly encountered organism is the Candida albicans, and it is if it is frequent, it will be seen commonly in the spine, and this is an example of fungal spondylodiscitis, where you got an inflammation of the L2-3 intervertebral disc being bright in the T2 weighted image, and the bone marrow edema of the opposing vertebral end plates. They are black in the T1 and bright in the T2 register. And after injection of contrast in this T1 fat set image, you got enhancement of the bone marrow edema, enhancement of the inflamed disc, as well as enhancement of the inflammatory granulation tissue. Actually, the fungal osteomyelitis is not different from the bacterial osteomyelitis in its X-ray, CT, and MR appearance. And in MRI, you may see bone marrow edema, which is black in the T1 and bright in the T2. You may got bone erosive changes, and you may got extension to the joint. The fact that fungus will appear of dark T2 signal is not clearly identified here in the infection of the bone. Then we came to the Brodus abscess, which is an intraosseous abscess and may be a sequelae of subacute bacterial osteomyelitis. This abscess can occur at any location and any patient age, and it is usually non-expansile, but sometimes if it is present in a small bone, it may be an expanding, and it may have a sclerotic or non-sclerotic margin, and may be associated with some localized perosteal reaction. This Brodus abscess commonly seen in children, and the Staph aureus is the most common organism also, as the case in osteomyelitis. The lesion occurs in the metaphyses of the tubular bones, and the most common sites are the proximal and distal ends of the tibia. The carpal and the tarsal bones may be affected, but extension across the gross plate is rare. This abscess may extend across the gross plate, but if the plate is open, there is, according to the literature, maybe the extension is not common. Then the abscess appears in an osteolytic lesion, and it is surrounded by a thick rim of reactive bone sclerosis. And this sign, which is a lucent line extending towards the gross plate before epiphyseal closure, is considered by the literature as pathognomonic for Brodus abscess. As I have mentioned, sometimes you got perosteal neobone formation, and you may got some soft tissue swelling adjacent to the affected bone. Then I will tell you about this penumbra sign. Then here you see that what I mean, a lucent line which is extending from the lesion towards the gross plate. And this penumbra sign is a high signal intensity rim and the T1 weighted image surrounding the abscess cavity, and it is just a sign. And you can see here, this is what we mean by the penumbra sign, where you got an abscess inside the distal part of the femur, and in the T1 before contrast injection, and you got this bright signal in the T1 weighted image. And these are two Brodus abscesses, one in the distal part of the femoral metaphysis, and the other is in the proximal part of the tibial metaphysis. And this is also another example of Brodus abscess that is crossing the physeal plate, and you can see the extensive surrounding bone marrow edema, and the lesion is of low signal in the T1, high signal in the T2, and if you inject contrast material, this the edema will enhance, and also you may be able to see some perosteal fluid collection along the distal part of the shaft of the femur. And this particular example of Brod's abscess in the distal part of the femur, and you see the cavity, and you see that there is some cortical breaching or erosion where the inflammatory material is coming outside the confinement of the medullary cavity, with consequent the development of some synovial effusion in the knee joint. Then we came to what is known as sclerosing osteomyelitis of Guérin, and this is a specific type of chronic osteomyelitis usually seen in children and young adults. It can affect the mandible and associated with odontogenic infection, and if it affects the long bones, there is overgrowth of the bone on the outer surface of the cortex, giving the appearance of an onion skin or an onion peel, considerable cortical thickening. And this is not a perosteal reaction, but there is continuous cortical thickening, and this is an example of a sclerosing osteomyelitis of Guérin. And here you can see the fulminant cortical thickening and the loss of the corticomedullary differentiation. Of course, this is completely different from Ewing sarcoma, for example, where you got lamellated perosteal reaction and you got destructive lesion within the medullary cavity of the bone, and maybe associated with abnormal soft tissue swelling in the surrounding soft tissues. And this is an example in the mandible. There is some increase in the size of the mandible with thickening of the cortex, and this is of low signal in the T1 and bright signal in the T2 weighted image, and you can appreciate the difference between the size of the mandible on the left compared to that on the right side. Then we came to this type of infection, which is known as chronic recurrent multifocal osteomyelitis, or CROMO. And this is an idiopathic inflammatory disorder, affects the children and young adults, similar to the previously mentioned one, and 85% of the cases are seen in females. The typical presentation is a young adult with chronic multifocal bone pain, and this they may be sometimes fever, weight loss, lethargy, but they are uncommon. If you take a biopsy from the osseous lesion, and you will not see any organism. Sometimes they thought that this type of osteomyelitis is of autoimmune etiology. The most common sites to be affected are the metaphyses of the tibia, but the literature considered the clavicular involvement is characteristic, as this site or clavicular involvement is uncommon for hematogenous osteomyelitis. Then this is one of the findings that I have seen frequently in the literature, that there is a significant increase in the size and the density of the medial part of the clavicle. And these are the typical locations of the disease: the metaphyses or metaphyseal equivalents of the bone, symmetrical anterior chest wall, long tubular bones and clavicle, spine, pelvis, sacroiliac joints, ribs, sternum, scapulae, mandible, hands, and feet. And this is an example of CROMO in the mandible. There is extensive areas of bone sclerosis and alternating with areas of osteolosis. And how can you suspect the possibility of CROMO in a certain patient? And number one, according to the clinical if there is chronic bone pain, then if you got a biopsy and the culture is negative for any organism, if there is a particular affection of the clavicle, the presence of systemic inflammatory features like inflammatory bowel disease. And sometimes they thought that this technique, which is known as whole body MRI, can help to scan the whole body for the areas of possible involvement. And the findings at the whole body MRI include bone marrow edema, perosteal reaction, soft tissue edema, extension across the physis, and the areas of contrast enhancement. Then the whole body bone scan also can help in the detection of the areas affected by chronic recurrent multifocal osteomyelitis, and I think you are able to see this particular affection of the right clavicle and also to a lesser extent the left clavicle and some of the metaphyseal parts of the long bones. Then the findings that can support the diagnosis of hematogenous osteomyelitis over chromo are. Then by these findings, you suspected that this is not chromo, but hematogenous osteomyelitis. If there are fluid collections, if there are abscesses, if there are fistula tracts, bony sequestra, and the bone scan or the MRI may show multifocal uptake in this disease, but the localized uptake in hematogenous osteomyelitis. In MRI is preferred, of course, in the children because of the radiation. Then the treatment of chromo is by non-steroidal anti-inflammatory and immunosuppressive drugs. This is a patient with normal X-ray of the ankle. The MRI showed bone marrow edema of the distal fibula and the tibia on both sides, and also bone marrow edema of the distal femur and the proximal tibia on both sides. And according to the literature, the differential diagnosis will include an infiltrative process like leukemia, but the distribution and the symmetrical appearance of the proximal femoral sparing are against the diagnosis of leukemia. Also, the diagnosis of Gaucher disease, there is normal radiographs and make Gaucher disease less likely. Then they thought of the possibility of chromo, and they have the biopsy which yielded inflammatory cells only, but no organism, and on this findings they reached the diagnosis of chronic recurrent multifocal osteomyelitis. And this is another case, and you see the affection of the proximal femora, and you got some lesions in the sacrum and iliac bone and also in the vertebrae. Then we came to the tuberculous osteomyelitis, which usually affects the extremities, including the small bones of the hands and the feet. In the children, whenever you see this lesion, which is an osteolytic lesion that has crossed the physeal plate into the epiphysis, and this is considered one of the pathognomonic features of TB osteomyelitis. And since the biogenic osteomyelitis do not usually cross the physis, but the tuberculous osteomyelitis can do so. And this is another example of tuberculous osteomyelitis. It is not common for TB to produce perosteal reaction, but in this case, it is an inflammatory focus associated with a perosteal reaction. Isolated TB osteomyelitis without TB arthritis is rare. because the tuberculous osteomyelitis can extend into the adjacent joints, and in 30% it affects the hip or knee, and 20% may affect other joints. One form of TB of the skeleton is what is known as TB dactylitis or the spina ventosa, which is a painless involvement of the short bones of the hands and feet in children. And the X-ray may show soft tissue swelling and periosteal reaction, and the bone is expanded, and gradually it will be destroyed and become necrotic with the formation of the sequester. Then this is an example of TB dactylitis, or what is known as spina ventosa. Of course, this can be easily differentiated from enchondromas, for example, by the clinical picture of the patient, and also by the appearance of the lesion, which is not a pure osteolytic lesion as you can see in enchondroma, and there is no matrix calcification as seen in enchondroma. The differential diagnosis of TB dactylitis include syphilis, pyogenic infection, fungal infection, leukemia, sarcoid, hemoglobinopathies, and hyperparathyroidism, that's the brown tumor. This is the difference between pyogenic osteomyelitis and TB osteomyelitis. The pyogenic osteomyelitis is acute and rapid. Tuberculous osteomyelitis is a progressive disease. Pyogenic osteomyelitis is extensive with diaphyseal involvement, and this is focal and may invade the joint and rarely involve the diaphysis. Epiphyseal affection is uncommon in pyogenic osteomyelitis but common in tuberculous osteomyelitis. The bony changes destruction and sclerosis, but in TB, destruction and osteoporosis. Periosteal reaction is common in pyogenic osteomyelitis but uncommon in TB osteomyelitis. The sequestra are common and large, and they are in TB uncommon and small. Then we came to a disease which is known as transient synovitis of the hip. And I have explained this in a lecture of adolescent hip, but here this transient synovitis is a self-limiting acute inflammatory condition affecting the synovial lining of the hip, and this may result in hip pain, and usually seen in the age between 3 to 8 years with some recognized male predilection. Over 90% of the patient may have hip joint effusion, and from its name it is due to synovitis, which is transient, meaning that it is self-limiting and may heal spontaneously. The exact etiology is unknown, and the viral etiology or trauma are suspected, and the radiographic features are non-specific, and all what you can see by ultrasound, CT, and MRI is just the joint effusion. And sometimes if you may inject contrast material, especially on MRI, and you may got synovial thickening and enhancement. Then the imaging findings of transient synovitis include hip joint effusion and synovial thickening, and sometimes we may get contralateral joint effusion, and also you may have some inflammation and enhancement in the surrounding soft tissues of the joint, but the bone is not affected with normal bone marrow, and the management is usually conservative. And this is an example: a female child, 8 years old, with hip joint effusion. The bone marrow signal is within normal, and also the surrounding muscles are within normal. Another example of transient synovitis on the right hip, and you see a synovial effusion, and actually you are not able to appreciate synovial thickening unless you inject contrast material to see the degree of synovial thickening and enhancement. Then we came to the juvenile rheumatoid arthritis, or the juvenile idiopathic arthritis. This is one of the most common chronic arthritic diseases of the childhood. The estimated incidence is about 13 per 100,000 per annually. Then symptoms for this disease to be diagnosed, the symptoms must start before the age of 16 years, and the females are more affected than males. In this disease, you may got oligo or polyarticular arthritis of more than 6 weeks, and the diagnosis, this is an essential feature to settle up this diagnosis. The presentation may be acute or gradual, and the symptoms may be worse in the morning but may present throughout the day. Intermittent fever, a migratory light pink skin rash may be seen like this, and hepatosplenomegaly. Then the juvenile rheumatoid arthritis may present by soft tissue swelling, osteopenia, narrowing of the joint space, bone erosions, and gross disturbance in the form of epiphyseal overgrowth or ballooning, active synovitis, joint subluxation, and the cervical spine. You got atlantoaxial subluxation, odontoid erosion, and ankylosis, especially of the facet joints. And this is an example which is not so much different from the previously mentioned disease, which is the transient synovitis. Then you got in the T2 weighted image, and you may see normal findings, but this is the appearance of a joint effusion, and as I have mentioned, you are not able to appreciate the synovial thickening unless you inject contrast material, and in the contralateral joint you also may see some of the joint effusion. And you remember in the lecture of arthropathies, I have mentioned that one of the features of rheumatoid arthritis in the juvenile form is the presence of rice bodies, which represents some debris inside the synovial fluid. If you inject contrast material, and you can appreciate the degree of synovial thickening and enhancement. Then juvenile idiopathic arthritis, rheumatoid belongs to this group of category of arthritis, and in order to diagnose juvenile idiopathic arthritis, there should be an onset in a patient less than 16 years old, and the condition lasts for more than 6 weeks, and the origin is unknown. Then what is the role of imaging in such conditions? Is to diagnose the presence of arthritis by the presence of inflammation of the synovium, intrasynovial fluid. There may be some erosive changes in the opposing surfaces of the joint. Then to exclude arthritis mimickers as osteoid osteoma causing pain, leukemia, and avascular necrosis. Early diagnosis is important because if you initiate treatment before joint damage, this will help to maintain the joint function and prevent its damage. Then juvenile idiopathic arthritis is a form of arthritis that should be detected before the age of 16, and the symptoms are lasting for more than 6 weeks, and then you do not identify a specific cause. The X-rays will help to exclude other causes, and the X-rays are not recommended for regular follow-up. Ultrasound is a very good tool, and it allows, as I have mentioned, the dynamic scanning. MRI is better for looking for the synovium. Then in this type of arthritis, you got synovial inflammation, and you got synovial thickening and enhancement, and this can be appreciated very well by MRI. If you use the Doppler ultrasound, then you may got some vascularity, but in many cases you may not see this vascularity. The constant finding is joint effusion and edematous changes of the periarticular soft tissues. And here, and this foot, and you got some enthesitis of the plantar fascia. Here you got some thickening of the plantar fascia and the abnormal signal, and this T2 weighted image. In cases of juvenile idiopathic arthritis, you may got bone marrow edema and periostitis, which can differentiate this from the transient synovitis, which is a disease localized localized to the synovium. Bone marrow edema is an important finding that may predict the development of bone erosion later on. In the children, the prognostic significance of bone marrow edema is not established, and you know that bone marrow edema is only detected by MRI. Enthesitis is inflammation at the tendon or ligament attachment to the bone. Periostitis or periosteal reaction is frequently seen in the periarticular areas of the hands and feet. Then periostitis causes enlargement and squaring of the affected bones. And this is an example of juvenile idiopathic arthritis affecting the wrist joint with some destruction of the carpal bones, and you may feel that there is some bony ankylosing of the intercarpal joints, and this has a close appearance to the rheumatoid arthritis, which is seen in adults, and sometimes you may mistake this for rheumatoid arthritis, but you remember, for the diagnosis of juvenile idiopathic arthritis, there should not be a known cause of this arthritic changes. And this is another example where you got some swelling of the periarticular soft tissues and the enlargement of the epiphysis and widening of the joint space, and these appearances may simulate the hemophilic arthropathy that I will explain in few minutes. Then we came to the septic arthritis, which means infection of the joint by bacteria, and this will result in significant swelling of the joint and severe inflammatory signs, as you can see here. Then the risk factors for septic arthritis are the presence of bacteremia, old age, immune compromised status, rheumatoid arthritis, intra-articular injections of contrast or drugs, and prosthetic joints like partial or total joint replacement. Then, in absence of trauma or instrumentation, the cause is blood-borne. Staph aureus, as usual, is the most commonly isolated organism. Then the commonly affected joints being the shoulder, the hip, and the knee. And in my opinion, the hip is the most common one clinically or seen in the clinical practice. Also, the sternoclavicular and sacroiliac joints may be seen, especially in intravenous drug abusers. And the patient will complain of acute inflammatory symptoms with pain, tenderness, swelling, redness, and high fever. And this is a good example for the progress of septic arthritis in the hip. At first, the X-rays will appear normal, as you can see here. Then you may got some displacement of the fat planes, indicating the presence of joint effusion, and also you may see some osteopenia due to reactive hyperemia. Then after cartilage destruction, the joint space will start to be narrowed. Then followed by cartilage destruction, there is destruction of the cortical bone, and you got erosive changes on the both articular surfaces of the joint in the acetabulum as well as in the femoral head. Then if these changes are not treated, you got sclerosis of the joint surfaces, and finally you may end by deformities and ankylosis of the joint. And sometimes you may use the ultrasound to aspirate some of the joint content for culture and sensitivity tests. 90% of the patients will recover with appropriate antibiotic therapy. And this is an example of septic arthritis of the right hip joint with narrowed joint space, erosive changes of the acetabulum, and maybe of the femoral head. Sometimes in the literature they use this sign, which is Waldenstrom sign, where you got some widening of the inferior medial aspect of the joint space. And this is a classic appearance of the septic arthritis of the metatarsophalangeal joint of the fifth toe, which is frequently seen in diabetics, where you got erosive changes, perosteal reaction, and in order for this to be diagnosed as arthritis, there should be changes in the opposing articular surface on the other joint line. Then these are the causes: hematogenous spread, or direct extension from osteomyelitis, or needles or trauma, or secondary to surgery. And in this example, you got hip joint effusion, which is seen well in the T2 weighted image. After injection of contrast material, then you got synovial thickening and enhancement. At this stage, you may call this synovitis, and this synovitis may be of the transient form or maybe of the septic form, and if left untreated, it may progress to cartilage destruction followed by bone destruction. And in this stage, ultrasound is good to have a sample of this fluid for culture to ensure that there is no an inflammatory organism or a type of bacteria. Then in the X-ray, as I have mentioned, you got soft tissue swelling around the joint. Then there is rapid destruction of the cartilage and bone, narrowing of the joint space, sclerosis, then bony ankylosis. And here in the shoulder, you see the anchors of previous surgery, and you got the swelling of the soft tissues, osteolytic lesions in the femoral head, and you may be able to notice some of the gas shadows within the soft tissues around the shoulder. And here also you may see the same changes with gas shadows within the soft tissues. And aspiration of this joint yielded pus, and the diagnosis of septic arthritis is settled. Actually, CT is good in this particular disease, where it can see the extent of destructive changes in the hip joint, and the extent of collections and abscesses within the joint itself, as well as the bone debris, and also the state of the joint, if it is dislocated or subluxated or migrated like this. And you see the femoral head has migrated upwards and is false articulating with the ilium. And another example of septic arthritis, and you see the collection of fluid inside the joint, and these fluids are marginally enhancing, denoting the presence of abscesses. Also, you see the migration of the femoral head and also the varus deformity also. And here is the axial images where you got thick marginally enhancing collections denoting abscesses, areas of destructive bony changes representing the osteomyelitis. And another example of severe osteomyelitis and septic arthritis around the ankle. There is destructive changes in the talus and the calcaneus, as well as in the distal part of the tibia and fibula, with destruction of the articular surface and extensive periarticular soft tissue swellings. Then sometimes you got in septic arthritis, you got total resorption of the bone, especially the femoral head, and maybe most of the acetabulum, resulting in this appearance. Ultrasound, as I have mentioned, is one of the best imaging modalities for number one, detection of joint effusion, number two, the detection of rice bodies or the debris inside the collection, number three, the assessment of vascularity, and number four, you got an aspirate from the joint content in a real time and a very quick procedure, and that can help you for assessment of the underlying organism. And this is by MRI, septic arthritis of the right hip, coronal T1 and coronal stere. You got bone marrow changes in the femoral head and the acetabulum, marked narrowing of the joint space, soft tissue swelling and edema surrounding the hip joint. And this is also another example in the T1, in the T2, and this is a stere and this is T2 weighted image, and you got the distension of the joint capsule by fluid, bone marrow edema of the acetabulum and the femoral head, and this is an indication of arthritis, not an osteomyelitis, because of the affection of the both sides of the joint space. Then this is an end stage of septic arthritis where you got resorption of the bone and the total ankylosis of the remaining part of the femoral neck to the iliac bone. Then we came to the tuberculous arthritis, and this is, according to the literature, is never a primary lesion. It is almost secondary to pulmonary or TB lymphadenopathy, and it is usually monoarticular, occurring at any age with no sex predilection. The most common site for tuberculous arthropathy is the spine, of course, but the hip is one of the joints that is frequently affected by septic and tuberculous arthritis. Also, the knee, ankle, sacroiliac, shoulder, elbow, and wrist joints may be affected. And the smears from the joint may be negative for acid-fast bacilli, but synovial fluid culture is positive in about 80% of the cases. And the X-ray, you may got this Phimister triad, which include periarticular osteoporosis, then peripherally located bone erosions, and progressive decrease in the joint space, as you can see here in this hip joint. And in the early stage of synovitis, you got periarticular osteoporosis. You may got joint space widening due to effusion, and you may got some erosive changes, exactly similar to those seen in the pyogenic arthritis. Then in the latest stage, which is the stage of erosion and destruction, you got gradual narrowing of the joint space with destruction of the articular cartilage, and you got erosions and also subluxation and even dislocations of the joint. And you see in this bilateral TB of the hip joints with dislocated hips. Then this may be followed by fibrous ankylosis according to the literature. Bony ankylosis is considered uncommon in cases of TB. Sometimes you got bone atrophy and atrophic arthropathy, which is seen in the shoulder joint, and this type of TB is known as caries sicca. And according to the literature, we have 3 types of shoulder TB. Type 1, which is known as caries sicca, where you got marked wasting and painful restriction of the movement of the shoulder. And type 2 is known as caries exudata, and there is a swelling of the joint with the formation of multiple cold abscesses and sinus tracts. And type 3 is known as caries mobile, where the active movements are restricted, but the passive movements are preserved. And this is an example of caries sicca, where you got destructive changes in the articular surfaces, and you got some atrophic changes of the surrounding muscles. You are not able to see the shadow of the deltoid muscle, for example. Then in MRI, you may see hyperintensity in the T1 and hypointensity in the T2 with significant contrast enhancement. And the low signal in the T2 is due to fibrosis and necrosis and the blood byproducts, which are considered rare in other forms of arthropathies. Then MRI can also assess any associated abnormalities with tuberculous arthropathy, like affection of the bone, affection of the muscles, affection of the skin and the subcutaneous tissues, the presence of para-articular abscesses, the presence of tenosynovitis, skin ulcerations, and sinus tracts. And this is an example of TB arthritis of the left hip, where you got destructive changes in the femoral head and the acetabulum, as well as significant edematous changes of the surrounding muscles. And this is an example of TB arthritis of the ankle joint, where you got the lesion in the distal part of the tibia, and you got inflammation of the synovium of the ankle, as well as the inflammation of the surrounding soft tissues. In this example, you got destructive changes in the wrist joint with destruction of some of the carpal bones. On MRI, you got extensive bone marrow edema, destructive changes in the carpal bones, and also you got fluid in the distal radioulnar joint, as well as in the intercarpal joints, together with fluid along the extensor tendon sheaths, which may indicate the presence of tenosynovitis. In one of the well-known manifestations of tuberculous arthritis is the osteoporosis resulting in hazy joint line. And in order to appreciate this finding, this is the normal appearance of the ankle, where you got the well definition of the cortical outline of the talus and tibia. But here you see the hazy, irregular, shaggy outline of the articular surfaces, together with some soft tissue swelling, which is considered a sign of tuberculous arthritis. Also, articular cartilage destruction is one of the late findings. So the joint space narrowing is also a late finding in TB arthritis. And if you look here, and there is considerable destructive changes in the hip joint, and after total hip replacement, then you got appreciable healing of the iliac bone lesion and some new bone formation around the prosthesis. Then we came to the hemophilic arthropathy, and you know that we have two types of hemophilia, hemophilia A and B, which is sex-linked recessive disease seen only in males and is associated with bony changes, while hemophilia C is not sex-linked, seen in males and females with almost no bony changes. And hemophilic arthropathy may be mono or oligoarticular. The presence of hemorrhage inside the joint will result in a swelling of the joint. There may be some fluid level due to the presence of synovial fluid and blood. The presence of chronic hemarthrosis and hyperemia may lead to enlargement of the epiphysis and deformities of the gross plate. Then in the plain X-ray, you may got periarticular soft tissue swelling, which is very dense compared to the adjacent muscles due to the presence of blood. Then it is usual for the same joint to be involved multiple times by intra-articular bleeding. Then the synovial hyperplasia and chronic inflammation with fibrosis, as well as hemarthrosis, are the pathologic underlying findings of this particular type of arthropathy. And synovial masses will erode the cartilage and the subchondral bone. The most commonly joint affected is the knee, then the elbow, ankle, hip, and shoulder. Whenever you have an imaging modality, which is in this case MRI, which is the best because it is able to see the synovial thickening, and is also to see the blood byproducts, including the hemosiderin by its characteristic low signal intensity in all pulse sequences, and you can see these hemosiderin depositions within the joint. Also, if you inject contrast material, you may got enhancement of the synovium due to irritative synovitis. You may got joint effusion, simple fluid rather than blood, and you may got articular cartilage erosion. Then there are some of the, let us say, pathognomonic X-ray findings, particularly in the knee joint. And one of them, as you all know, is the widening of the intercondylar notch due to intercondylar bleeding. Then the increased density of the periarticular soft tissues, distension of the joint capsule by hemorrhage, disuse osteoporosis due to limited joint mobility, and chronic synovitis with cartilage destruction and joint space narrowing. Then we have four sites for bleeding: intercondylar, intraosseous, supraosteal, and epiphyseal. Intercondylar will lead to widening of the notch, which is considered one of the pathognomonic signs of hemophilia. Then intraosseous hemorrhage will lead to osteolytic lesion, which is known as hemophilic pseudotumor. Supraosteal hemorrhage may cause perosteal elevation and supraosteal newborn formation, and epiphyseal hemorrhage may result in premature fusion and deformities. And then this is a hemophilic arthropathy of the knee in an advanced stage where you got the development of secondary osteoarthritic changes. Then how can you know that this joint is affected by hemophilia before it has developed this extensive degenerative changes? It is the history and the previous films that can help you to predict the diagnosis. Then, of course, the sign of widening of the notch may be lost by the time of the development of these extensive osteoarthritic changes. And this patient is also affected the elbow and the ankle joint, but the ankle here is the last one to be affected. And one of the characteristic findings is the talar slanting or the medial sloping of the tibia of the talar articular surface may be one of the diagnostic criteria. But of course, whenever you have MRI and you see these big masses of persistent low signal intensity in all pulse sequences, and if you inject contrast material, these masses will not enhance, and they are able to differentiate this from pigmented velonodular synovitis, since the synovitis will enhance if you inject contrast material. Then hemophilic pseudotumor is one of the rare complications of hemophilia, which is seen in less than 2% of the hemophilic patients, and it may develop in the muscle or the bone of the pelvis, especially, or the lower limbs. And this is because that the pelvis and lower limbs have abundant blood supply. This is usually a big lesion, which is usually unilocular or multilocular, osteolytic, expanding of variable size. It can affect the metaphysis, the diaphysis, and the epiphysis, with these manifestations in the plain film, including endosteal scalloping, lesional osteo or perilesional sclerosis, and cortical bone thinning or thickening, trabeculations and septations, together with pathological fractures. A hypointense rim of the pseudotumor is seen in T2 and T1 weighted images due to fibrosis and hemosiderin deposition. And this is an example of a hemophilic pseudotumor in the forearm, where you got significant destructive changes and expansion of the ulna, and you can see the huge soft tissue component. And this is the hemophilic pseudotumor of the pelvis. And the plain X-ray, you see a dense soft tissue shadow around the joint, and here you see a collection that has a thick margin with some internal hyperdense foci or possible calcification, and also erosion of the adjacent iliac bone. This is the MRI of the same case, showing the low signal intensity rim of hemosiderin and fibrosis around this hemophilic pseudotumor. Then we came to the Charcot joint, which is known as neuropathic arthropathy. And this joint has three underlying pathologies: the ischemia, the infection, and the disturbed sensation. This Charcot joint is commonly seen in diabetic patients because they have the three factors contributing to the development of this Charcot joint. Charcot joint is typically unilateral and may be bilateral in about 20% of the cases. The causes of Charcot joint include diabetes, syringomyelia, some of the neurologic problems like spinal trauma, brain injury, also leprosy, neurological diseases, congenital insensitivity to pain, and intra-articular steroid injections. We have two types of Charcot joints: the atrophic form, which is the most common and occurs earlier and has an acute progression with resorption of the ends of the affected bones, joint destruction with resorption of the fragments, and there is no osteosclerosis or osteophytes. And this occurs in the non-weight bearing joints of the upper limb, like you see here in the elbow. And the hypertrophic form, and this is a slowly progressive disease where the sensory nerves are affected. And you got joint destruction with periarticular debris and fragmentations, widened, then destroyed joint space, osteosclerosis, osteophytes, no osteoporosis unless the development of acute infection. Then the joint looks like it has, as if it has been hit by this hammer. Then you got significant destructive changes, bone sclerosis, and joint derangement with, from the literature, the 6 Ds that are characteristic of Charcot joint. Density change, meaning that there is subchondral osteopenia or sclerosis, destruction, osseous fragmentation and resorption, debris and distension of the joint due to effusion, disorganization and dislocation, joint malalignment due to ligamentous laxity. And you see this ankle joint in the frontal and lateral view. On MRI, the T1 weighted image will show low signal intensity, ulcerated skin, some soft tissue gases, and soft tissue swellings. If you inject contrast material, most of the areas will enhance, apart from the areas of necrosis and pus collections. Then in the STIR image, you may see bone marrow edema and soft tissue edema as well. Later stages will lead to loss of demarcation of the cortical bone and cortical destructions. If superimposed osteomyelitis has occurred, then MRI may show the presence of sinus tract, bone marrow edema, some soft tissue edema, marginally enhancing lesion denoting abscesses, joint erosion, and this ghost sign, which indicates that the margin of the lesion will not appear clearly unless you inject the patient with contrast material in order to enhance the bone marrow edema. Then you are you will see the margins of a collection or necrotic bone more better. Then this is an example of Charcot joint, which as I have mentioned, is the sequelae of 3 superimposed factors, which are the loss of sensation and the decrease of the blood supply and the super added infection. There are some of the measurements that can help you to see the changes in the foot, especially in these patients with Charcot joint. And this is the Meares angle, which is the angle between the axis of the talus and the axis of the metatarsal bone. This angle will be widened whenever the foot is collapsed. And also the angle which is known as the cuboid height, and here you draw a line from the undersurface of the calcaneus to the cuboid bone. Then you measure the angle with the sole of the foot, and if there is some flat foot, let us say, which will occur due to destructive changes in the intertarsal joints, and this angle will be reversed. And you see this angle is by positive degrees, now it is by negative degrees. The literature divides the the foot and ankle into 5 regions, and they indicated that the most common 2 regions to be affected by Charcot joints are region 2 and region 3. This is region number 1, and this is number 4, and this is number 5. This is an extensive destructive changes of the ankle joint with many debris and almost total erosion of the talus and most of the superior surface of the calcaneus, as well as the distal part of the tibia and the fibula. And this is also the appearance by MRI. You got soft tissue inflammation with phlegmon formation, let us say that. And one of the best values of this MRI is to detect well-formed abscesses, and they are of interest for the surgeons to be evacuated either in the diabetic foot or in the presence of Charcot joint. Then we have some few remaining issues about the inflammation of the muscles and the inflammations of the skin. And we start first by the inflammation or the infection of the muscles, which is known as infectious myositis or myositis, which is seen in young adults. And these are the risk factors like HIV, muscle trauma, cellulitis, infected insect bites, and the injection of drugs, diabetic patients, and also the Staph aureus is the commonly encountered organism. Then the inflamed muscles may transmit the infection to the adjacent bone, resulting in osteomyelitis, or adjacent joint, resulting in septic arthritis. Then biomyositis is characterized by 3 stages. The invasive stage, where there is edema in the affected muscles leading to pain. Then the suppurative stage, where the patient develops fever, and the late stage, which is life-threatening and may lead to toxicity and symptoms and sepsis. Then here you got biomyositis with multiple marginally enhanced abscesses within different muscle groups of the thigh, and the diffuse high signal represents the muscle edema. And this is infectious myositis in diabetic patient, where you got inflammation of the vastus lateralis and adductor magnus muscle. They are not clearly seen in the T1 weighted image, but they are well appreciated in the STIR image and also after injection of contrast. What is important is to detect well-formed marginally enhancing abscesses, which are not present in this case, and also to assess the integrity of the bone, which is also healthy in this case. Then here you got infectious myositis with the formation of an abscess, where you can see the marginally enhanced lesion. The MR findings will include, or imaging findings in general, diffuse muscle swelling, stranding of the subcutaneous fat, marginally enhancing abscesses, obliteration of the intermuscular fat planes. If it is spread to the bone, you got osteomyelitis. If it affects the artery or the vein, you get vascular thrombosis. And if it is in the leg, you may got compartment syndrome. Soft tissue abscesses are similar to any abscesses anywhere in the body. And you got a collection of pus which is surrounded by a capsule, and this capsule is enhanced if you inject contrast material in the CT or MRI. Then you see an example of multiple abscesses intra-abdominal and also in the back muscles. Then we get to the dermatomyositis, which is an autoimmune inflammatory myositis, as well as inflammation of the skin. Dermatomyositis. This is important to differentiate from other forms that I will mention now. Then this is closely related polymyositis, which carries an increased risk of malignancy. Then we have two types of dermatomyositis, the juvenile form, which is seen in the children, and the adult form, which is seen in adults around the age of 50 years. The presentation by symmetrical proximal myopathy with skin changes, as you can see here. The skin is dusky red rashes over the face, arm, hands, legs, and with development of papules. And you see these papules. Sometimes the patient may present by dysphagia, myalgia, fever, weight loss, and other features. Then there is a six-fold increased risk of malignancy in dermatomyositis, and these are the factors which contribute to the increased risk. Number one, elderly patient, the presence of dysphagia, the presence of accelerated onset of the disease, the presence of skin necrosis and cutaneous vasculitis, the increased creatine kinase levels, the increased ECR and C-reactive protein, the presence of interstitial lung disease or inflammatory arthropathy or Raynaud's syndrome. Then this disease is easily diagnosed from the plain films by the presence of sheets of dystrophic calcification in the muscles and the soft tissues. And this is known as calcinosis universalis. Calcinosis universalis means that there is calcium in the soft tissues, in the skin, as well as in the muscles. The calcium is in the form of sheet-like densities and may be seen everywhere in the body, and may be associated with acroosteolysis, which means resorption of the distal phalangeal tufts. And in some patients, the barium swallow may show the decreased peristalsis, like exactly you see in scleroderma, which is one of this category, as I will mention. Then MRI will show hyper-intense signal throughout the affected muscles due to myositis, which means that there is some sort of edema. The calcific areas will appear of low signal, but the plain films are better for detection of calcification rather than an MRI. And here you can see this is the appearance of the normal thigh muscles, and this is the appearance of the muscles affected by dermatomyositis. And here you can see the diffuse muscle edema with you may feel that there is some subcutaneous edema as well. Then this is the reconstructed image, which show the extensive edematous changes or edematous changes of the thigh muscles with relative sparing of the leg muscles according to the literature. Patients with dermatomyositis may have chest involvement, and the pulmonary changes are almost similar to those seen in usual interstitial pneumonia, which means that there are extensive interstitial opacities with honeycombing interaction bronchiectasis, and this may be seen in about 45% of patients with dermatomyositis. And calcinosis universalis means that you got calcium in the skin or the subcutaneous tissues and also in the muscles. And then 1/3 of these cases are associated with scleroderma, dermatomyositis, polymyositis, and the systemic lupus erythematosus. Then you may got subcutaneous calcification extending along the facial planes with possible tendon and ligament involvement. You remember that there is a form of calcinosis which is known as tumoral calcinosis, and this is have been explained before. It appears in the form of masses in the soft tissue calcification related to the joints, which are not affected usually by these masses. But here you got sheets of calcium, not masses. And this is a good example where you see extensive subcutaneous soft tissue calcification in the chest wall, and also you can see the same changes in the muscles and the subcutaneous areas of the anterior abdominal wall and some of the posterior abdominal wall. Then what is calcinosis circumscripta? And this means that there is calcium deposition in the subcutaneous tissues, and it is considered a localized form of calcinosis universalis, and commonly seen in women. And most of the cases are idiopathic and commonly present in the hands and feet. There is some association with Raynaud's phenomena, scleroderma, and dermatomyositis in about 40% of the cases. Patients present by firm white dermal plaques or nodules. And you see these nodules of calcium that are present in the subcutaneous area. And here you can see the classic appearance of calcium deposited in the soft tissues of scleroderma, and you may also see resorption of the phalangeal tufts. Then eosinophilic fasciitis means that there is inflammation, or let us say, and this is a connective tissue disorder of the fascia. It is not affecting the muscles. It can be seen in any age and is also well recognized in females, especially of the extremities. Other supportive diagnostic features is the presence of peripheral eosinophilia, hypergammaglobulinemia, and elevated ESR and C-reactive protein levels. Then you got scleroderma-like cutaneous changes. You may see facial thickening without myositis, and this is the appearance of the skin, and the changes are usually symmetrical. And the MRI, you got affection of the facial planes, but the muscles are not affected. If you inject contrast material, the fascia will enhance. If you want to confirm the diagnosis, and this will be obtained by biopsy, then the biopsy should be deep enough to include part of the muscles in order to reach the diagnosis, and the disease responds well to corticosteroids. Then this is the appearance, MRI T1 post contrast, and you got enhancement of the facial planes, but the muscles are not involved. Then this is also another example. This is the T1, and this is the T2, and this is the T1 post contrast, and you got enhancement and thickening of the facial planes, but the muscles are spared or not affected. Finally, we do a few words about necrotizing fasciitis, which is a rapidly progressive and fatal infection with a high mortality rate, may reach up to 75% of the cases. The disease affects the deep facial planes, the skin, and the underlying muscles may be affected. It's commonly seen in immune-compromised patients, like those with HIV infection, diabetes, cancer, alcoholism, and organ transplant. Sometimes there may be an underlying cause of trauma or retained foreign bodies, for example, and the organism in charge may be polymicrobial, a group of organisms, or a single organism, which is commonly the A-type streptococci, which is known as the flesh-eating bacteria. The treatment requires urgent surgical fasciotomy with the debridement of the necrotic tissue. The plain film may show soft tissue swelling and gas, which is not present in most of the cases. Gas is only seen in a minority of cases. But the value of CT is to show the degree of soft tissue necrosis, the presence of internal hemorrhage and pus collections, and also it is more sensitive than the plain film to detect gases if they are present. Then these are some of the non-specific findings, which include asymmetric facial thickening with fat stranding, muscle and intermuscular septal edema, soft tissue abscesses may be present. Alhamdulillah Rabbil Alameen. Thank you very much.